Today, I have the enormous pleasure of speaking to Dr. Nick Birch, who is an orthopaedic surgeon and a fellow of the Royal College of Surgeons in the UK. Nick is the founder of Osteoscan UK. And Nick reached out to me because I believe, Nick, you were looking for for an NPR article, which is called I've actually forgotten the name of it. Do you recall the name of it? It was basically how a prescription grew to fit the drug or something like that. And it was essentially on, what the late great Dr. John McDougall called the broken bone business, and how the invention of DEXA scanning essentially enabled this whole invention or creation, let's say, of a disease category of osteoporosis and osteopenia. And so Nick, you reached out to send me some info on REMS, which is radio frequency echographic multispectrometry. Spectrometry.
Yep.
That's hard to say. I'm just going to call it REMS henceforth. So, yes, Tell my audience about REMS and why you thought I'd be interested in knowing more about it.
Well, thanks very much, Robin, for the invite to come and talk to you today. It's a real pleasure, and I'm delighted to have a chat about REMS and various other aspects of bone health. You're right. The article was called "How a Bone Disease Grew to Fit the Prescription," and I was looking for the original NPR link to this, because I actually have a copy of it which I give to my patients, but it's about 7 megabytes. So if I send an email, it takes up a whole chunk of email space. So I wanted the link, and as I came across a link, then there was somebody who had actually, I think, had been seen or treated by you or helped by you, and I thought that was very interesting. So I then went down the rabbit hole, which was the Robin rabbit hole, and this is how I came across your website. That was where the link was. And I thought this is fascinating, because what you are saying and what I believe and what I tell patients is so very much aligned. So I thought, hang on a second, you're in Queensland, and my very good friend Dave Tongarini, who's in Melbourne, who runs the REMS service in Australia, I thought you two really ought to be put into contact with each other, because this is something that you might find of interest. REMS is Italian. It's a great development of some serious ultrasound science that started in the early 2000s. And it led on from what you may have come across before, which is quantitative ultrasound. So you ever come across the people who put their foot in a water bath, and then you have an ultrasound scan of the heel bone, and you transmit sound through the bone and look at the way the sound has changed. And that can then give you an understanding of their bone health. The problem with quantitative ultrasound, or QUS as it's called, is that it's not good enough to really give you an accurate numerical result for your bone density. So it can give you a category, it can give you normal or osteoporosis. It's not very good at giving you the so-called diagnosed osteopenia. So it's not therefore recommended for follow-up on maintenance. If people are on treatment, then you can't really follow them up. So scientists
jog my memory, because I do recall many years ago some pharmacies in Australia were offering this, what they just called a heel ultrasound, which is, I presume, what you were talking about. I guess my impression is that was superseded by the widespread availability of DEXA scanning, which I'm sure we'll get to shortly. Okay, so the relationship between REMS and this earlier quantitative ultrasound then?
A whole bunch of very clever ultrasound scientists in Rome at the National Research Laboratories realized that quantitative ultrasound was not going to be an adequate alternative for measuring bone health in an accurate way. And they looked at it, instead of thinking, well, how does sound get transmitted through bone, and therefore you transmit sound on one side of the heel and then you collect on the other side and see what happens to it. What about if they look at how sound's reflected from bone? Does that tell us anything more? Turns out it tells us a huge amount. So they then worked through, it was about 15 years of development in Rome, and the research laboratories there. And they realized that they could look at the reflected sound, what's called backscatter, And the backscatter tells us a couple of things in very simple terms. I mean, I'm an orthopedic surgeon, so I have to understand things in simple ways. One of which is absolute how much sound is coming back. You know, if you think about it, if more sound goes through the bone and less comes back, then there can't be as much bone there. So that's one way to think about it. And the other way to think about it, so that will give you an idea about bone density. But the other way to think about it also is, well, how much sound is being scattered? Because if you have a crystal and you bounce sound off a crystal, because all those very regular edges, the sound doesn't scatter very much. It's a very narrow pattern of scatter. But if you have a blob of sponge or hard sponge, it's all over the place because it's not well organized. And so what they did then was they worked out how to look at bone that was very well organized and then not well organized. And they could then correlate that with who had fractured and who hadn't fractured. So uniquely, what REMS does is not only gives you the ability to measure bone density, and it has been validated many times against DEXA. So it goes up against DEXA very well. It's as good as DEXA. And that paper that we talked about previously from Nick Fuggle and his team in August of 2024 showed that it's actually a good alternative to DEXA. But on top of that, uniquely, it offers you direct measurement of bone toughness at the hips and at the spine, and you measure that in real time. So the key to REMS is that it's ultrasound, so therefore it's completely safe. You can do it as many times.
So this is non-ionizing radiation in contrast to DEXA. So this is the paper by Fuggle, this radiofrequency echographic multispectrometry in the diagnosis and management of osteoporosis. So this is a paper that you very kindly sent me. And so this paper essentially showed that there was a strong correlation between DEXA, which is considered the standard of care, and REMS measures of BMD, but that the additional benefit of REMS is that it provides this fragility score, which is a measure of bone quality as opposed to just the quantitative measure of bone mineral density. And that's really key. So it was, I believe it was this article that you found me through, the Great Osteoporosis Game.
It was.
This was the one in which I discussed this article or this production by NPR, How a Bone Disease Grew to Fit the Prescription. And the point that I made in that particular article was that essentially DEXA is just an incredibly poor predictor of fracture risk because it's looking at the bone density, but that's not the same as the bone quality. Is that a reasonably accurate summary?
I think it's a completely accurate summary. Despite what the systematic review that the US Preventative Services Task Force relied upon in their recent publication in the Journal of the American Medical Association, who said that DEXA is a very accurate way to predict fracture risk. Well, I think most people working in bone health around the world realize that actually that is not the case.
Yes, just published. January 14th. Yeah. So this is the US Preventative Services Task Force, which conducted this extensive evidence review, systematic evidence review, and came up with this guidance, which, as I understand it, is not particularly different from their previous guidance, which is that women over 65 should have screening for osteoporosis. That they said that it had moderate net benefit, but of course they're specifically referring to DEXA as the recommended screening technology. And I really liked your comment in our email correspondence about this, that your jaw dislocated and fell onto the floor when you read this, that there is, essentially backing DEXA and saying, oh, it's a really good predictor of fracture risk. So what say you, Dr. Birch?
Well, I mean, they were talking about detection here, those recommendations, and it says the USPSTF found adequate evidence that centrally measured DEXA, BMD, bone mineral density, can accurately predict osteoporotic fractures in women. I just found that to be absolutely astonishing because it's been known for decades that is not the case. And the reason why FRAX and other fracture prediction tools was developed was because DEXA could not accurately predict. And for the US task force to say this, I just find to be beyond belief, really. So if they are hanging their coat on this statement that this test is going to accurately predict fractures, then it means that the rest of the recommendations you have to look at and say, well, actually, is that actually built on a solid basis of hard rock? Those, or are they built on clay? Is it built on sand? So I'm suspicious of the
Indeed,
recommendations.
and there was an accompanying editorial in that same issue of JAMA by Susan Marie Ott, and I've highlighted a couple of passages from this which I think are really, really worth paying attention to. So she writes, another question that has been neglected is whether treatment should be based on the underlying cause of the bone loss instead of the risk of a fracture. And I think in a minute, let's just quickly review bone physiology for my audience. So the process of osteoclast breaking down bone in order for osteoblasts to go into those spaces and build it up. But so she writes, physiologically, it does not make sense to treat a patient who has low bone turnover with a drug that further blocks the bone resorption, which is what the bisphosphonates do, and also what the newer monoclonal antibody drugs do. So she goes on and said, studies should pursue the utility of adding markers to bone density to increase the accuracy of fracture estimates. That is, again, as I understand it, where REMS comes in, as well as decide which medication would be the most appropriate. And yes, this was really important too. More research is needed to describe the long-term effects of osteoporosis medications. And you and I were chatting before I hit the record button about some of those long-term effects and perhaps even medium-term effects. So bone loss continues inexorably with aging, and not enough attention has been paid to the drug effects beyond the relatively short duration of a randomized clinical trial. Some of the anticipated effects on the bone itself were estimated on the basis of the physiology of bone. Since bone resorption is a necessary step in repairing damage to the bone tissue, inhibiting the resorption will result in accumulated damage, lower new bone formation, and increasing mineralization that can make the bone brittle. And of course, after 5 years of use, you get this increased risk of atypical fractures. So very rapid bone loss following discontinuation of denosumab. I have a client who actually suffered that. She was having denosumab for injections for a number of years, and then she stopped, and within a couple of months, she had a series of absolutely ghastly fractures because we stop taking it and you get this vigorous resorption of bone. So really, really nasty stuff. Yeah. Okay. So anyway, lots to talk about there. So you were, I gather, not terribly impressed by that US Preventative Services Task Force assessment of the evidence.
No, I wasn't. I think Susan Ott's commentary actually, given that she started that editorial by saying nearly 40 years have passed since I wrote an editorial about screening bone density when I said it was premature to use these tests for screening. I was impressed. I mean, this is a lady who's a researcher who's got a very, very impressive academic record, and she's looked at things over a 40-year lifespan. Most researchers are going to be looking at over a lifespan of a much shorter than that. So she's got the vision to be able to see what's happened in the past, and I'm old enough, and if I had a hair it'd be grey enough, but I'm old enough to look back also over a 35 to 40 year time span, and I can see when I was training as an orthopaedic surgeon, we didn't have any treatment for osteoporosis. It was a terrible condition to have to treat. Now there are clearly changes that have occurred over 40 years. However, we mustn't get drunk on our own wine. I mean, at the end of the day, if you take alendronic acid and you say, okay, well, we're going to use it for primary prevention of fractures, osteoporotic fractures, what is the real benefit? And as you said, just before we came onto this, we were talking about the latest literature, and 2 days ago there was a Cochrane review by Wells and colleagues, which is literally published on the 27th of January, looking at alendronic acid and these bone drugs for primary and secondary prevention. And what this has shown is that there is actually very poor evidence that in primary prevention, and these are the people who you've had a DEXA scan because they've had some screening, and then somebody said, oh, look, you've got osteopenia, therefore you don't have normal bone density, therefore you should take a drug. But actually, they've actually said that there's really very little evidence. And what evidence there is poor quality. So there's a bit more evidence for secondary prevention. So that's over 75 years old, having had a previous vertebral fracture.
Yes.
With a diagnosis of
just for our audience, let's clarify. So primary prevention is a woman who has not had a fracture which would be classed as a low trauma, right? I mean, obviously, if you barrel down a mountainside skiing and hit a tree, one can reasonably expect to get a fracture. But so this is a woman who has not had a previous fracture in those circumstances, but she has, say, a DEXA scan and is told that she's at high risk of fracture. So that's a primary prevention case. And what do we see? Clinically important differences were not observed for the following outcomes. Hip fracture, so the relative risk was 0.76, but as we were discussing, the confidence interval crosses 0, so it's just not statistically significant. And what do people worry about? They worry about hip fractures. And then, as you said, they classified that as low certainty evidence. So this is not good quality research on these bisphosphonates. And so these are drugs like Fosamax. I mean, they're all out of patent now, and so their trade names like alendronate are being used. But these are the mainstays of osteoporosis treatment.
Yeah. So I think that's actually right. And one of the things also that review said at the end of the review, it basically said that the evidence is uncertain about the effects of alendronate on withdrawals due to adverse events. They basically said there were no atypical femoral fractures, there were no cases of osteonecrosis of the jaw. But what you said earlier was absolutely true, and that is that because the randomized control trials did not go on for long enough to detect these, and so the effect of the RAMKL antagonist, so which is denosumab, with the rebound effect causing multiple vertebral fractures on withdrawal, unless you have a bisphosphonate to prevent that from happening, that effect was only seen well after the randomized control trials had ended. And of course, what the Cochrane review has done is to look at the RCTs and found, of course, that these are following up for 2, maybe 3 years. But of course, the atypical femoral fractures, there was a good review by Paul Anderson in the Journal of Bone and Joint Surgery last year, showing that these actually start after about 3 years of treatment, and therefore the incidence begins to rise at 3 to 5 years.
Whoa! Yeah.
So it takes a while.
5 to 7, but 3. That's frightening. That's frightening. Sorry.
I was going to say, and exactly the same for osteonecrosis jaw as well. If you need to have the bone completely soaked in the bisphosphonate for this suppression of bone turnover to then cause these sorts of problems. And these randomized control trials actually never went on for long enough because they were all industry sponsored. So there's all huge risk of bias. Only a fraction, 8% of the RCTs that the Cochrane group looked at actually were high quality trials. The rest all had significant risk of bias.
And yet we're talking about something that is considered the standard of care for both primary and secondary prevention. And it really is. It's built on sand, isn't it? Could you just very, very quickly review bone physiology for my for my viewers? So what's the process by which bones grow or are built and then are broken down as people get older?
Well, very simply, when we're born, we have no calcium in our bones. We just have cartilage. And then as you grow and you get older, you get more and more calcium formed. So calcium is clearly a key to bone physiology. The best calcium is from food. It is absorbed in the gut and in its bloodstream with the assistance of vitamin D3, and then it gets into the bloodstream, and effectively it then gets into bone with the vitamin K2 and magnesium, and they're the two key component that actually allows it to get into bone. And what it wants to do is to meet up with protein. So elemental calcium from food needs to turn into mineralized calcium with protein, and that's then forming bone. And so the process of that is then facilitated with vitamin B9, which is folate, vitamin C, manganese, boron, copper, and zinc. So these are all chemical reactions that turn calcium from its elemental state into the mineralized state. Once you've got the ability to make bone, then you can look at bone and say, okay, well, how does bone respond? It's one of the most metabolically active tissues in the body. It is continuously turning over. Every time
that's surprising to a lot of people, isn't it? Bone seems so inert, but it is an incredibly active, metabolically active tissue.
It is. But you see, if you jump, you put a shock through your bones, and that then causes some of the bone cells called osteocytes to send messages, first of all, to the osteoclast. And it's basically saying, hang on a second, guys, I've got a shock through the bone here. I need to have a bit of reinforcement. I've got some bone there that I don't need. So please, Mr. Osteoclast or Miss Osteoclast, please take away the bone that I don't need. And then I want your helper, which is the osteoclast, to come put some raw bone down. And then I want you to model it and to turn it into a decent strut. When I was a registrar doing orthopaedics, I thought that the osteoclast was my enemy. I thought that actually osteoclast just took bone away. What I realized actually is the osteoclast is the friend. And the way to think about this is to think about a brick wall. Now, a brick wall is made up of bricks and mortar. Okay, so you think about the density of that. You say, okay, well, you've got a whole pile of bricks and you've got a whole pile of mortar. You can have the two side by side. And one is not built and one is built. Who builds the wall? Well, the osteoblast is the bricky's mate who brings the mortar and the bricks to the building site. But you need the bricky, which is the osteoclast, to actually sculpt that, to put it together, to turn it into something structural. And that's the way to think about osteoblasts and osteoclasts. So osteoclasts are not our enemies. Osteoclasts are our friends. They turn immature bone into mature, good structural bone, and that's what we need. And that's why it's so important not to suppress the process of bone turnover to the extent that actually you only then have immature bone laid down by osteoblasts, which is exactly what Susan Ott says. That gives you brittle bone. You don't repair microfractures. You don't repair the damage that's the normal process going on in bone. And as a result of that, then you can start to get these secondary effects.
So this is the point that I really want to underline, just in case anyone watching this has missed it. The current treatments for osteoporosis inhibit the action of those osteoclasts, the Bricky's laborers, as you put it. So they stop the breakdown and the removal of that immature bone, or the way that I've always understood it is the osteoclasts kind of clean up the damaged bone, the bone that's maybe suffered some microfractures and so forth, and needs to be remodeled. So the drugs, the bisphosphonate drugs, and the the newer drugs, the denosumab and so forth, they're inhibiting the osteoclast. They are not stimulating the activity of the bone building cells, right?
No, you're absolutely right there. So the drugs that do that are the anabolic drugs. So that's teriparatide, abaloparatide, romosozumab, and they're a completely different class of drug. But they, of course, are very expensive. They're injections, and that's a different class. But the standard ones that you're absolutely correct that are handed out. As anybody has a test that says, hey, you've got a diagnosis of, here's the drug, then it's one of the bisphosphonates or it's denosumab.
Yes. Okay. And so the longer people stay on these drugs, the lower will be the quality of their bones, and therefore they are at higher and higher risk of what's called an atypical fracture. So the classic instance of this would be a femoral shaft fracture, where your femur, your thigh bone, like big, heavy, chunky, thick bone, just snaps right down the middle. I mean, just awful. And also the osteonecrosis of the jaw problem, which results in a lot of people's dentists sort of saying, I'm sorry, I can't help you. I dare not, drill into this jaw because it's likely to just die. You're going to lose your implants or whatever have you. Horrifying stuff.
Yep.
So all that. Let me summarize where we're up to so far. So we've got this sort of this standard of care technology for assessing the mineral density of bones, namely DEXA, or dual energy absorptiometry, correct?
Yep.
Which is an X-ray, and therefore it involves ionizing radiation. We're all assured, of course, that it's a low dose, but it's still ionizing radiation. So you can't have one of these every second Tuesday to see how your bones are going, right? I mean, yeah. And so DEXA measures bone density, but not quality. The advantage of REMS then is that it measures bone density, and from the papers that you have sent me, it measures bone density just as well as DEXA, but it has this added benefit of measuring the quality of the bone, which involves all the processes we've just been discussing, like, how solid, how solid is the mortar, how well mortared together is your brick wall. And being
there's one rider on that, actually, sort of, Robin, and that is that there is a mechanism. There's a mechanism for DEXA to measure quality of bone. It's called the trabecular bone score, and you can measure it by looking at a grayscale analysis, basically a pixel analysis of the spine DEXA image, and that can give you then an understanding of bone toughness. But it can't measure bone quality in the hip. So the difference between REMS and DEXA, it gives you bone quality, hips and spine. Some DEXA will give you a trabecular bone score, but it's an added software package. In the UK, certainly most hospitals do not have it, and in Australia it may be the case as well. But there are some. But yeah. So just as a rider, just to make sure that we're telling the truth here.
Okay, thank you for that clarification. Now, I have looked at a lot of my clients' DEXA scan reports, and I haven't seen any indication of this trabecular measure of trabecular quality. So I don't think that it's standard here. I certainly haven't seen that. Yeah. Okay. So REM, the one of the advantages of REMS then is that measure of bone quality is built in. A second advantage is that it does not involve ionizing radiation, so it is safe to have the procedure done fairly regularly, I guess, to assess, say, response to treatment.
At least once a week. I mean, they must come to me once a week and have a REMS test every week.
Ka-ching, ka-ching. No, of course. I mean, it doesn't need to be that frequent, but people can have follow-up REMS without the worry of continual exposure to ionizing radiation. So that's a bonus. I notice also that REMS can measure body composition. So again, DEXA scanners can be configured for that purpose. But is there any special configuration that's needed for REMS to assess body composition, or is that standard?
No. It actually comes if you have a REMS machine, and there's an extra module that you have for body composition. Essentially, what it does is it looks at the ultrasound images of the spine acquisition. So when we do a REMS scan of the spine, you're lying flat on your back. You don't have to move. There's no great positioning. And any woman who's had a DEXA scan will know that there's a lot of positioning to do with DEXA to get it right. But in REMS, it's not. It's very simple. And we do an ultrasound over the tummy, and we look at the spine directly. And in doing that, what the clever ultrasound scientists at Echolite have done is to be able to use the information they're getting back from the broadband ultrasound to analyze your visceral and subcutaneous fat. They also look at the thickness of the muscle. But it's really important, because if you've got a visceral fat level, I mean, for instance, in a 60 to 65-year-old lady, you'd expect 32 to 34% visceral fat level. I mean, that's fine. I mean, if you've got that and you're slim and you're fit, etc., you know that you're metabolically fit. Yeah, it's we've measured visceral fat. And visceral fat, we know, of course, is the big indicator of being metabolically not fit, with systemic inflammation, macrovascular disease, and metabolic syndromes, etc. So it's a really important aspect, because if you see someone who is unexpectedly high in that, you say, well, hang on a second, look, this may be something that you've never considered before. You might need to go away and actually have a look at some of your labs and look at see what's going on. Why is it you've got a high level? So it's actually really quite an important cardiovascular and metabolic addition to also look at bone health. We know that if you've got systemic inflammation, then the likelihood is that you're going to have some impairment of bone health. So linking the whole thing together is really important.
Yeah, that's fascinating. Yeah, and then I mean, the obvious other benefit that I could see of assessing body composition is that osteoporosis and osteopenia, whether or not you kind of accept those disease categories, that was what my article was about that got us together. But anyway, people can read that. I'll link it in the notes. But the other obvious benefit is that osteoporosis often coincides with osteosarcopenia. So you've got this loss of lean tissue and replacement of lean tissue. Lean tissue meaning basically anything that isn't fat, right? So that's organs, that's bones, and then that's muscles. And that particularly for women postmenopausally, there's this progressive loss of lean tissue and gain of fat tissue, especially visceral fat, thanks to changes in hormones, which means that, well, women's body composition is changing unless they do something about that, even if their weight is not increasing. And of course, it's muscle pulling on bone, which sends the primary signal to those bone building cells, right? Well, that plus impact.
Yeah, no, you're absolutely right. And of course, that's resistance. And of course, there is actually a very famous researcher in your parish called Belinda Beck, who's at Griffith University in Brisbane, and she is, to my mind, she is the world's best and most brightest researcher in this area. And of course, she was the originator of the Lift More study, which showed exactly that. Effectively that you can help women postmenopausally who've got either low or very low bone density using exercise, resistance, and impact, and effectively stopping that postmenopausal loss of lean tissue. And by doing that, you can then prevent fractures just as well as you can by taking a medication. And there's really good
without
evidence.
The risk of the atypical fractures and the osteonecrosis of the jaw and the atrial fibrillation and all the other nasty things that happen. Yeah.
But the evidence is very clear that a high protein diet with adequate bone nutrients and a good exercise program involving impact and resistance is just as good as any bisphosphonate without the side effects.
And of course, that same, the improvement in dietary quality and the exercise is also beneficial for preventing, cardiometabolic disease. It lowers the risk of breast cancer and colorectal cancer and stroke and all these other conditions. Oh, and dementia, of course, all these other conditions that, of course, become more and more common as people get older. None of which, bisphosphonates do not prevent any of those conditions. And of course, there's the heightened risk of cancer of the esophagus, at least with the oral bisphosphonates. So, yeah, lot of downside, not much upside. So could we just briefly discuss the ideas of sensitivity and specificity in relation to diagnostic technology? Don't need to go into a tremendous amount of detail. I think it's just important for my audience to understand the limitations of diagnostic technologies and what it actually means when they get handed a DEXA scan report that says that they have this T-score and this heightened risk of a fracture and so forth.
Can I get you to put up on the screen that 2023 paper by Paola Pisani that looked at the fragility score?
Yes.
And if you scroll down to the receiver operating curve analysis, I think we can use that as a very good way to look at sensitivity and specificity.
This one here?
Yeah.
Yep. Okay.
So if you go down, you'll find 4 graphs.
Yep.
Keep on going.
Let's see. Further down. Okay, these are the ones?
Here we are.
All right.
Okay, here we are. All right, that's fine. Perfect. Okay. So as you said, if you look at these graphs, on the left-hand axis, on the y-axis is sensitivity, and on the x-axis, the horizontal axis, is 1 minus specificity. So basically what this is doing is looking at the ability of the test to detect the thing that you want to look for. And in this case, it's fractures, it's fragility fractures. So what the REMS group did under Paola's leadership was to, they did REMS and DEXA scans back to back. So same hospital doing them and same people doing them. So these are very controlled conditions. And what they then did was they followed these people for up to 5 years, and there was almost 2,000, so it's a good sample. And they followed for up to 5 years, and then they would check in on them every 6 months and find out had they had a fracture, had they not had a fracture, how were they, etc., etc. And what they found was fascinating. So if we start off with the top left graph, what you're looking at in that horizontal, that diagonal is that's the position where you've got no idea whether the test actually detects it or not. So that diagonal means it's neither detecting or not detecting.
Yep.
Anything to the left of anything to the left of anything to the left of that means that the test detects the thing you're looking for. Now, the green and the blue lines, they're graphs, they are the T-scores for REMS and DEXA. Therefore, that's the bone density. Whereas the red line is the fragility score, that's the bone toughness. And the bone toughness is closer to the top left than either of the DEXA T-scores or the REMS T-scores, which means that for women, LS is lumbar spine, FBM is femur. So women, for the lumbar spine, the fragility score is better than the T-score. Therefore, the sensitivity and the specificity is higher for them. Therefore, you've got a better test. For the femur, it's much better in the women. That gap between the red and the green, the blue is much better. For men, exactly the same. Basically, the fragility score is the better test. So when we're looking at sensitivity, when we're looking the key here is that you've got sensitivity and specificity is how well does a test do?
Yes.
And the answer is the T-scores don't do very well at all.
Yes. So sensitivity means you want the test to detect the condition if it is there, and specificity. Correct me if I get any of this wrong. Specificity is you don't want the test to detect it if it isn't there. Is that more or less it?
So basically, it's about true positives and true negatives. Exactly right. That's right. It's the ratio between true negatives and true positives.
And so when you look at this DEXA, so the DEXA is actually crossing that line. Which means that So just explain what the DEXA crossing this line means for women, just in relation to that femoral density.
I think if you look at that, just take one step back and actually look at the overall trend of that graph, and that graph is for the DEXA is pretty much on the line of zero. It's not predicting the fractures. The fact is, it's a little bit below in the upper part and a little bit above in the lower part, on average. But if you look at the REMS T-score, the REMS T-score is above the line of zero difference all the way through. And in fact, it is on all the graphs apart from men's femur in the very lower part where there's a little bit crossing. But you're right. But the DEXA effectively is basically saying it cannot tell you whether you're going to get a fracture or not. It's not good enough. This goes back to what we were saying about the US task force. I mean, how on earth they actually say, okay, look, this is one study and in its high controlled environment, etc. However, I don't think it's that far away from the general truth about how good DEXA is for predicting fractures. And I think most people would agree with that.
So I can tell you from my clinical experience, and I'm sure you've had the same thing, when women, and it is mostly women, come in with a DEXA scan report and it says, your T-score in your femoral neck is minus 2.8 or whatever the heck it is, they have the fear of God put into them. Their whole self-concept changes. I've seen this happen to many women. They go from feeling pretty good, being active, being confident, going hiking, this sort of thing, to having this, they actually cut back on their physical activity because their DEXA scan report gives them the sense that they're very fragile, and now they have to watch their step and not do anything dangerous because they might have a fracture. And you look at this and you go, this is no better than a coin toss in terms of actually detecting which women are at risk of having an osteoporotic fracture of the femoral neck, which, by the way, just for those of you who are not clear on this, the femoral neck is what is meant by a hip fracture. So it's not in the hip bone, it's not in the pelvic bone. A so-called hip fracture is actually the neck of the femur, this sort of narrow shaft of bone, or narrow section of the thigh bone. This is pretty shocking, actually. Thank you so much for clarifying that, Nick. And I do hope that for women who have had a total psychological crash after having a DEXA scan, they'll feel a little bit better and not think that they're cripples or something, because that is truly awful. Yeah.
Well, this is what REMS has provided us with, and we know from that Fogel paper that there are some very, very serious people in the world who understand osteoporosis and metabolic bone disease who've actually said that REMS is as good as DEXA and is a good alternative. They've looked at this and they've said, actually, no, we can believe this. This is absolutely fine, because this is telling us about bone toughness.
Yes.
Now, a good example of this is it's actually in the animal world. Do you know what the smallest bird in the animal kingdom is?
Smallest bird? Goodness me. No, I don't.
It's the bee hummingbird in Cuba.
Okay. Yep.
It's 5 centimeters long. It weighs about 20 grams.
Tiny.
Yep. And it hovers, flapping its wings. She flaps her wings 80 times a second to hover to get the nectar out of the plant. Hummingbird with long beak, etc. Okay, so that's the smallest bird in the animal kingdom. So 20 grams, and she's flapping her wings 80 times a second. By definition, she has to have ultra low bone density.
Yes.
But by definition, she has to have ultra high toughness.
Yes.
Okay.
Indeed.
Now, what links her to a 2-ton elephant?
Goodness me, you got me there.
Well, so the answer is a 2-ton elephant. So you know, and I know that the more load you put through bone, the denser it becomes. Therefore, if an elephant, the elephant's the largest land mammal. She weighs 2 tons. She therefore has bone density off the scale. So you've got a bee hummingbird with bone density off the scale on one end, and an elephant with bone density off the scale on the other end. However, the elephant, she occasionally has to run at 30 miles an hour, 50 kilometers an hour to you guys, to chase lions away from her calf, which means that her bones have to be ultra tough as well. So what links the hummingbird and the elephant is not bone density, it's the toughness.
Yes.
And they're both completely adaptive for their environment. However, if of course they had a bit of an ache and they went to the veterinary rheumatology clinic, the rheumatologist will have every hummingbird on bisphosphonates.
That's hilarious. Oh no, you've got low bone density. And
so when you say to a woman, if you say to a woman, you've had a DEXA scan and you've got now I see women who've been told they've got osteopenia.
Yes. And
they have to go on alendrolic acid because they've got this thing that's inevitably going to become osteoporotic, and as a result, you're going to you have fractures, you'll end up in a wheelchair, etc., etc. Now, the context of this is really important, Robin, because if you have a woman who's got a family history of osteoporosis, and many hundreds of women I see have either a mother or a grandmother who's had they've had spinal fractures, they've got this widow's hump, they've got that's right, yep. So they basically they're thinking, am I going to look like mum? Am I going to look like grandma? And what can I do to prevent this? And then you go to see somebody who said, well, you just had a DEXA scan and your T-score is minus 2.4, which means you've almost got osteoporosis. And if you don't take these medications, you will have fractures and you will end up in a wheelchair. And suddenly catastrophizing. And it is horrendous. It is horrendous. Every practitioner.
I was going to use the word criminal, and that might be overstating it. It's not.
No, I don't think it's
criminal. It's kind of morally criminal.
It is certainly institutionally misogynistic.
Yeah,
it is absolutely ridiculous.
Thank you for pointing that out, by the way, because women really are the targets of this, far more so than men.
No, I have this conversation with every single practitioner I ever discussed this with, and yesterday I was talking to one of the premier menopause specialist in the UK, Louise Newsom. We were talking about hormones, and why is it that more women aren't actually offered hormones at the time of menopause? Because you're replacing the thing that they've lost that actually keeps them bones health. And of course, then that's because that's misogynistic as well, because men don't want to sort of make women feel good. So yeah, there's a lot of rubbish in all of this.
Oh yeah,
anyway,
there's crazy on the crazy.
if you instill fear into somebody, you get something called fear avoidance behavior, which is well described. A painful condition. You've got a painful ankle. You will not put weight through that ankle because it hurts, and the brain says don't do it, etc., etc. So fear avoidance behavior is a natural, normal part of human reaction. However, if you instill it as part of a medical consultation, that I think is completely unprofessional. And in that sense, I think that is not doing what doctors should be doing, which is actually making people, hopefully making them better. It's actually making them worse, because exactly as you say, once a woman has been told, if you keep active, don't lift anything, don't do anything, stop running, stop exercising,
don't even have a vigorous hug, with your grandkids, because they might snap your bones. Yeah,
it's not. It's worse than that. It's worse than that. I've seen marriages break up because women believe that if their husband hugs them or they have intimacy, that somehow they're going to break. Therefore, suddenly a marriage disintegrates because of this fear. And I've seen divorces happen as a result of it. And
no way. That's something I've never seen, and that is just completely horrifying. But I believe you, because I have seen women whose, as I said before, that their entire self-concept just changes overnight, and it's awful. So really, I mean, what the take-home message that I want people to get out of this is, don't let the results of a DEXA scan that you might have had determine how you think of yourself. B, there's this crucial element that your DEXA scan has left out, which is, what is the actual integrity of your bone, or the opposite, like how fragile or not fragile is your bone, because that is a greater determinant of your propensity to fracture than bone density. Which reminds me, one of the very early treatments for osteoporosis was, of course, fluoride, because fluoride is amazing at increasing bone density. Oh, look, we've just measured your bone density and it went from awful to great. Oh no, the fluoride actually made people's bones more brittle, and then they fractured more. Oopsie. And
it's interesting, actually, because fluoridation of water has been such a hot topic of conversation recently, because I think one executive order that Donald Trump has signed since being inaugurated is to stop the mandatory fluoridation of water, because of the exactly as you say, because of the risks that are there. I mean, okay, so fluoride might make teeth a bit better and prevent dental caries, but what else does it do? And, and when you're looking at population health, you're sort of thinking, okay, what are the harms of this? If you throw a medication at a population, be that a bisphosphonate or be that fluoride or be that anything else, what are the harms? Do we follow it for long enough? Do we really understand that? So we were talking earlier about the harms of bisphosphonates. There's a recent paper, literally just came out a month or so ago, looking at glaucoma. So, use of bisphosphonates, particularly risedronate, increases the risk of glaucoma. We know that then bisphosphonates lead to atrial fibrillation and serious. We know that bisphosphonates therefore are cardiotoxic. They're not going to do the heart a huge amount of good. So all of these things eventually come out, and the question then is, what's the balance between risk and benefit? And if you've got a small benefit and you've got then a small risk, they actually might balance, and therefore, do you really want to take that drug? It's very clear. If you've got an antibiotic that's going to cure your infection, there's a massive benefit. But if there's a tiny risk of an allergic reaction, you're prepared to take that, because actually that's so much on your side. But if the risk of benefit is 1% and the risk of side effects is 1%, really? Do you want to take that? Do you want to do that? I don't know. So
yes.
I'm
so what do we call this? This is an informed consent discussion. And so few patients really, truly receive informed consent on testing, on diagnostic technology, on treatments, on surgeries and other procedures. So few, and surgeons, by the way, are so much better at informed consent than regular doctors. I mean, I haven't had any major surgeries, but I've had a few minor procedures, and I've got to say the informed consent process was excellent compared to...
Are you telepathic?
Sorry?
Are you telepathic, Robin?
Could be.
Well, I was having a discussion with my wife last night about informed consent, and my concern that actually informed consent when it comes to medications, particularly with bone health medications, because that's what I deal with mostly, is actually inadequate. And I wrote a couple of papers a few years ago following what's called the Montgomery case. Now, the Montgomery case in UK law basically specifies that you have to provide enough information for the woman to make her own decision. So this is a shared decision-making process, but the doctor's responsibility is to provide enough information for her to make that decision. She needs to have as much information as she requires for her own purposes. She needs the time and space to be able to then process that information. She needs to be able to come back and ask again what her questions are, and then she needs to have her decision respected. Yes. That's the important thing. So they're the Montgomery principles. Yes. In medicine, if we don't do informed consent in surgery, when I was operating as a spinal surgeon, if I didn't go through an extensive process of informed consent and something went wrong, then my indemnity would be having to pay out a large amount of money because actually I've been negligent. And so that's the whole point. I don't see that in the world of bone health, in the world of metabolic bone medicine. I just do not see that.
At all. No.
A woman needs to have enough information for her use. So she defines how much information she needs. It's got to be her decision. She needs to have time and space to be able to then process that information. She needs to have the opportunity to ask questions again, and then she can make that decision as part of a shared decision-making process. I do not see that happening outside of the world of surgery, pretty much, or of basically any surgical procedure. And I
completely agree.
Utterly wrong.
Yeah, I completely agree. And this applies to patients being prescribed bisphosphonates, patients being prescribed statin drugs, patients being prescribed all rheumatoid arthritis drugs, you name it. I've not, I'm not taking any drugs, so I haven't been through this myself. But when I speak to clients who have been prescribed various drugs, the classic case is SSRIs. Oh my goodness. There is no informed consent process in the prescription of SSRIs. And I have seen some absolutely shocking cases. By the way, heads up, SSRIs also increase the risk of bone fracture, just saying. No, informed consent, what happened to that? I mean, I'm assuming that in your medical training, you were taught like this is the right way to give a patient informed consent. What's happened?
So I don't know. I'm not entirely sure what's happening in medical training now. When I trained in medicine, actually, that was 40 years ago when I qualified. Consent in those days was paternalistic. It was basically, leave it to me, my dear, we'll sort it out. By the way,
don't you worry your pretty little head about that. Yeah,
that's exactly right. It was really, really paternalistic and sort of really, really patronizing. As time went by, then things changed, and it wasn't until the 2000s when there was a landmark case in the UK in about 2001, Chester versus Afshar, that really put it into perspective to say you have to give women the right amount of information to make a decision. And then that was updated in 2015 with the Montgomery case. Mm-hmm. So in surgery, we absolutely kept up to speed with informed consent. And now, I don't see that happening, as I said, in medicine or in other specialties, in diagnostics, etc. Why not? I don't know. How can it change? I'm not in a position to change it. All I can do is I can say that it is damaging to women's physical and mental health. There's no doubt about that. I see that on a daily basis. If I can, I will start to do what Debbie Robinson, she's a great yoga teacher and a gut specialist in Los Angeles, I've done a few podcasts with, and she says that she sees women exactly the same as you. They've had the rug pulled out from underneath them. What we've got to do is try to put the rug back underneath them. And then what I hopefully do with some of my consultations with REMS and with diet and exercise advice is actually to put that rug underneath and give them back permission to say, look, you're not as fragile as somebody's made out, and you can do stuff. If you haven't done exercise for a long time, start slowly, gradually build up. Get a personal trainer who knows how to do these things.
Well, see, an exercise
if
you're really concerned and you want that extra level of training. Yeah.
But also, see somebody who's got good knowledge of diet. Get the diet right. I mean, the modern Western diet is so poor in many respects. Getting that right and getting the exercise right. Hey, it's not difficult in saying it. It's difficult doing it.
It's difficult doing it. Yeah. People need a lot of coaching as well as the right information. And just to tie a bow on the informed consent issue too, because it doesn't seem like there's any pressure from within, you might say, for doctors to give proper informed consent. Unfortunately, and this is really unfortunate because it shouldn't be the patient's job, but it's going to be. You actually have to demand informed consent. And I coach my clients in, like, these are the questions to ask the doctor, when the doctor wants to send you off for a test. Well, okay, doc, what is it you're looking for? Are there any other ways to find it? What will happen if I don't have this test? I've read about this other one. Could you explain why the one you recommended is better than this one? Why shouldn't I have the one that, and don't tell me that I found it on Dr. Google, because doctors look up Google. I've had clients tell me this. Their doctor in the middle of a consultation is Googling the condition that they have. I mean, it doesn't exactly inspire trust. Oh dear. Patients actually have to demand informed consent until this whole issue is fixed in the medical profession. God knows when that's going to be. So
I think one thing, Robin, though, is that it's too easy for doctors to say, look, here's a tablet for you to take. If you read the data sheet, it'll tell you all about what that tablet you need to know. They kind of think that's informed consent. There you've got the data sheet produced by the manufacturer, which necessarily is going to underestimate the harms, because that's exactly what they do. They might listen and say, okay, you've got all these various bits and pieces. Oh, but don't worry about it. It's such a rare thing. It never happens. It's
yeah. I've never seen these side effects. Really? Well, have you looked?
Yeah.
Yeah.
No, I'm very suspicious of that process.
Indeed, as am I. So you've been so generous with your time. If I could, I wanted to essentially. I'm not doing this to get a free consultation, right? But I figure I'm probably a pretty good case study for what REMS might be able to do. So I'm 53. I'm 4 years postmenopausal. I have a mother who has suffered not one but two osteoporotic fractures. So she's had a pelvic fracture. She's actually had a femoral fracture, even though she wasn't on bisphosphonate, so femoral shaft rather than neck. Let me see. So there, I suppose my risk factors. I did have low bone mineral density when I was younger because of, I'll be honest, I had an eating disorder. So there are my risk factors. Now, on the positive side, I'm very physically active. I walk, I lift weights, I lift heavy. I eat a whole food plant-based diet. I eat soy products. I eat tons of greens. I eat plenty of plant protein. What benefit would I get from going to your lovely nurse practitioner? Well, not your one, but the one who kind of services my neck of the woods, Joe. Yeah. What benefit would I get with that set of risks and the things that I'm doing to mitigate those risks? What benefit would REMS offer me?
Well, let me ask a couple more questions before I answer that question. One of which is, are you taking hormones?
No.
Okay, so that's one thing to consider, because you've lost estrogen. And the question then is, do you need to replace estrogen? So that's a first consideration, because there is no doubt about it that anybody under the age of 60 who's postmenopausal has a huge benefit from taking hormones. In 2002, there was a study by David Reed and his team, and they showed that by taking HRT, you could have an absolute risk reduction. It's not relative, an absolute risk reduction of fragility fractures of 52%. Now that's stunning, isn't it? Absolute. That compares to things like alendronic acid, where you're talking about absolute risk reductions between 1.5% and 2.5%. So really, there's no doubt about it that I would say to any woman in your situation, first of all, consider hormones and actually get a menopause expert opinion regarding hormones. That's the first thing. Second thing is, what is your weight? I know it's rude to ask a lady a weight, but what's your weight?
I've already told you my age, so it's all on the table now.
No, I want to know your weight. Yep.
So my weight is 58 kilos, and I'm
Okay.
160, just under
No,
167
don't need a height.
centimeters. So my BMI is 21.
Okay, so you've got normal BMI in the lower half of the normal range, which means you're going to have a lower than average bone density by definition because of Wolff's law. Wolff's law is this law that says the more load you put through. This is the elephant being very dense and the hummingbird being very light, very non-dense. But the fact is you've got a weight of 58 kilograms and you're 54 years old. Now I can use what's called...
Don't give me the extra year yet, please.
I can use there's a very simple equation called the osteoporosis self-assessment tool, which I can use. And basically what it says is that if we take your age from your weight and then multiply that number by 0.2, whatever number we come up with, depends on where the cutoff is, we can tell whether you're going to be osteoporotic or not. And that was developed in the Far East, in the Philippines, where they had, in 2000, they had a population of 78 million, but they only had 4 bone density scanners in the whole of the Philippines. Of course, the Philippines is largely an island nation, and they needed to have a very quick and easy way to be able to triage women, to say, if you're on an island, you need to travel to Manila to go and get a bone density scan, yes or no. How can we do that? So all they needed was a pair of scales, so they could just measure the weight. So I've just done the analysis. I've been got a researcher doing it with me, and we have found that for REMS there's a cutoff of minus 0.2. If you are above minus 0.2, the chance of you having osteoporosis is extremely low. If you're below minus 0.2, the chance of having osteoporosis is extremely high. So that's our cutoff. So if we do your calculation, 58 minus 53 equals 1 times 0.2 equals 0.2, i.e. positive. Therefore, you're above the cutoff. Therefore, you should have a T-score of around about minus 2.2, minus 2.3 in your hips. That's normal for you. That's exactly what you should have. That's what Wolff's law says. You should not be osteoporotic. And it may be that you're slightly better. It might be slightly better than that just because you are very active, etc. The other question I'd ask you is, in an absolute sense, how much protein do you have in a day? You said you've got lots of protein. Have you actually done an audit?
Oh my goodness. I haven't for quite some years. In fact, the last time I would have done it was actually, a uni assignment some years ago. But yeah, this is something that can be easily done with the likes of, say, Chronometer or MyFitnessPal. So, okay, good. Thank you. You put that on the map. I will actually log a couple of days food intake.
Okay, so you need on average, if a woman's active, she needs about 1.5 grams per kilogram of body weight of protein per day. So you need 90 grams a day. Okay, so what does 90 grams look like? Well, if you were a meat eater, 90 grams is 3 breasts of chicken. That's a lot. That's a lot.
Yep.
If you're not a meat eater, if you don't eat meat or fish, then to get your protein from plant-based sources, you've got to work quite hard. This is what I said about working hard. It's easy to say good diet, good exercise. It's actually quite difficult to make it work, because to get 90 grams of protein from a plant-based diet, you need to know exactly where the sources of protein are. So do you have dairy at all?
No, I don't. No.
Okay, so the sources of protein you're going to get could be nuts, pulses, seeds. That's pretty much it.
That's
maybe
it.
Some grains, etc.
Yes,
that's a lot of nuts, pulses, and seeds. That's a lot.
And some vegetables, particularly green vegetables, they're very low calorie, but on a calorie for calorie basis, they're quite high in protein. So, by the time you add in veggies, fruits don't really count that much. They're very low in protein. I have done this analysis, as I say, some years ago, and it's actually surprising just how all the vegetables and the grains and the seeds and the nuts and the tofu and the beans, they do add up.
Yeah, but I have this conversation quite frequently, and I actually have key bone nutrient sheets where you get them from for an omnivore, for a dairy-free, for a vegetarian with dairy, and also for a vegan. And I'll send you those. They're fine. They're
great, terrific. That'd be a fantastic resource.
But they're quite useful, because what they do is they give a woman an opportunity then to look and see what the diet actually involves. Say, okay, what's got high protein, what's not got high protein, and we know now that protein is so important, and you have to have more protein as you get older, because women eat less as they get older. So proportionately, the protein has to go up, because otherwise we go back to the osteosarcopenia, because the protein, of course, is absolutely key for your bones and your muscles and your soft tissue. So if you don't have that protein, that's really important, and it's not going to be helpful. So I think doing a protein audit for most women is actually quite useful, perhaps every couple of years.
Excellent
Make sure they're on
advice.
track.
Yeah.
And just look at that and say, okay, fine, where am I getting my protein from? Am I getting adequate protein? And is that then being integrated into my musculoskeletal system? And if it is, then you're doing as much to protect yourself as possible.
Yep. Okay. Good. Excellent. Good advice. And so just to reiterate what we were talking about before in relation to exercise, the two primary types of exercise for improving bone density are weight training and impact. So with weight training, you're working on increasing the muscle mass. The muscles pull on the tendons, which pull on the bones, which signal the bone building cells, hey, we need you, make more bone. And then impact sends electrical signals again by tendons to activate bone building. So a lot of older women that I see are like that. They'll tell me that for exercise they walk. I'm like, walking's nice. It gets you outdoors. You get some sunshine. You get some vitamin D. It's really not going to be enough, especially as you get older, to maintain and hopefully increase your muscle mass and your bone density. Okay, so
Can I disagree with you slightly on that?
Sure.
Given that we've had 100% agreement so far, so here's a 1% disagreement.
Excellent. Bit of spice.
Okay, so listen, walking can be enough as long as one, you carry extra weight. So if you are if you're a 54 to 55, 60 kilogram woman, carry either a weighted vest or a pack on your back with 3, 4, 5 kilograms.
Weighted vests are amazing, aren't they? They're so good. Yeah. I got a 10-kilo weighted vest a while ago and started wearing it while I was out walking my dog. Oh my goodness, going up hills in particular with a 10-kilo weighted vest on, that's something else.
Well, that's for your cardiovascular fitness. That makes you fit. But actually, coming down the hill is the important bit for the bone. Because when you want to come down, you want to come down like the elephant. You want to be coming down. When you come downstairs, pretend you're an elephant. Come down heavy. Jump off the bottom step. That's the impact, etc. But when you're walking, change the speed, because bones respond to different loads and different frequencies. I.e., if you go fast sometimes, go slow sometimes. So you want to change the load, change the frequency. And if you do that, walking can be enough as long as you do enough of it. But you need to be walking 7 to 8 kilometers a day.
Yes.
So it's 2 hours of walking a day. Now, in an active person who's doing 10, 15,000 steps a day, etc., and then going out for a walk for half an hour, 3/4 an hour to walk that staffy that they might have hanging around watching a walk, that's absolutely fine. But then as you get older, as people get arthritis of the hips and knees, it becomes increasingly difficult. And for them, of course, then there are alternatives, which is, you can do Belinda's Onero program, which is relatively low impact. That's absolutely fine. That's easy enough to find online. But also things like whole body vibration. And so there's a whole range of different assistive technologies that will allow women, therefore, to take over those impact exercises and the resistance. And they're the two, resistance and impact. And things like, if you go to Pilates, doing reformer work, that's really phenomenal resistance work. And, it's great. So there's lots of different things you can do. Rebounders. I mean, you can if you've got hip and knee arthritis, you can go on a rebounder. And a rebounder is actually a really gentle exercise, but it's really valuable for both muscles, for balance, for preventing fear of falling, and also for bone health. So there's lots of exercise programs that can be done.
Marvelous. Yeah. So there's something for everyone. Yeah. Older age arthritis, no excuse. There's an exercise program for you. Yeah. That's fantastic. And so is there anything that I haven't asked you that you really wish I had of?
No, I don't think so. I mean, I think the key here is that I would love to see women come to my clinic who were not fearful. I see 700 or 800 women a year, and 650 of them have had results from their bone density scans or consultations with doctors or with nurse specialists or whoever it's their fracture liaison groups, who are coming along fearful because they've been told something that isn't necessarily the full truth. And what I'd love to see is that fear disappearing. And maybe these sorts of conversations that you and I've had, that I've had with Debbie Robinson, that I've had with Sophie Shutter in London, maybe that'll start to shift the dial a little bit. But we just need to have, I think, a re-examination of where medicine is in the 21st century, particularly regarding bone health, and how we can stop this process of instilling fear. Now, there's lots of discussions that we can have about other things where fear is being instilled, and recent events, etc. But my focus is bone health, if I can do that, I'm pessimistic. I can do a little bit of the UK, and thankfully there's an increasing number of people who think similarly. But it's going to take a long time to turn around the super tanker of medicine to get it back on track. And I think that super tanker has drifted off a long, long way from where it was when I first was qualified as a doctor 40 years ago. In those days, we really had the best interest of patients at our hearts, and we did the best we possibly could. We didn't have all the drugs. We didn't have all the fancy tests. And that's, I think, the problem, that if you give a doctor all the drugs and all the fancy tests, they tend to go down that route. They don't then consider the patient themselves. It's not sitting there listening to the patient, listening to her concerns and saying, okay, fine, how do we do the best for you? And that's what I'd like medicine to get back to.
Wow, I could not agree more. I would, as you do in the UK, we here in Australia have quite a number of doctors who have been trained in, let's just say, less wealthy countries than Australia and the UK, where they don't have lots of machines that go ping, and just a little Monty Python call back there. And I find that their physical examination skills and their willingness to actually do a physical examination, and also their diagnostic skills, are actually better than doctors who have been trained with all the bells and whistles, all the machines that go ping, and the limitless availability of pathology testing and whatever. Our doctors just don't seem to be trained terribly well to diagnose people without referring them off to some lab or some specialist. And as for bedside manner, look, I mean, obviously I live just outside a small country town. We're not well supplied with GPs, and I would say we have a really, really excellent GP in my little town, who's wonderful. He will sit and listen to patients. He's great, but a lot of my clients, they don't report such good fortune as I have here. So,
but that experience, unfortunately, that experience is worldwide.
Yeah,
and I've seen patients from all around the world now who've come to me with DEXA scans that are that are worrying to them, etc., and they wanted a REM scan. And so when we sit and talk to them, and my consultations consist of sitting and listening to a woman first of all, then doing the REM scan, and then sitting and talking, listening, giving them advice, etc. No consultation I do is ever less than 40 minutes.
Yeah.
And quite a lot of them up to an hour. And if a woman needs longer than that, she needs longer than that. That's absolutely fine. But
wow.
I think
that's so refreshing to hear. That's really amazing. And I'm not a fan of GMO and cloning, but I wish there was actually some way to not clone you, but to somehow replicate your care for patients and send it out into the world of doctors without cloning, which I'm really not keen on.
We just need to find a sort of an academy somewhere to sort of just train people properly to go back to medicine as that was 40 years ago. Yeah. There's a great book by Seamus Omani. He's a retired gastroenterologist from Ireland, which basically looks at the how medicine's changed and how it's perverted. And it's I think it's effectively, why did medicine stop being good medicine? And I think Seamus goes into a lot of that, and a lot of what we've discussed today, things like sort of the randomized control trials and evidence and all those bits and pieces, and what's actually influenced that. That's all come in the last 40 years, and it's gone from the golden age of medicine, where after the Second World War, I think doctors were exactly as you said. They had time to listen to people, they had time to make a diagnosis. They didn't have every single test going, and they didn't have the machines that go ping. So they were good doctors, and if somebody wasn't cured, well, the doctor tried their best. But now where you've got every single test that you can possibly imagine and every single drug you can possibly imagine. And then, of course, if they're not cured, then the patients go back and say to the doctor, well, you didn't cure me. It must be your fault. Well, in that sort of situation, then not surprisingly, doctors actually then change the way they behave. And I think that, in terms of medicine, in terms of ethics of medicine, we've got to take a step back. And we know that medicine's become deprofessionalized over the years, and I think that's a real worry. So, real worry for me, because I'm now so old. I'm going to need to be seeing doctors, but I don't get to see doctors because I think if I can't make my own diagnosis, then goodness knows no GP will.
Yes, it is a general policy of mine to minimise my contact with the medical profession, because with all the tests and the machines and whatnot, they're going to find something. So my approach is, look, I'm doing everything that I know how to do to keep myself healthy. And, if I get bitten by a snake, I live on 5 acres. We have eastern browns, so that's a fairly high likelihood. If I get bitten by a snake or I, cut my leg open or something, I'll go see a doctor. Otherwise, it's very, very rare. So, okay. Thanks so much. You've been incredibly generous with your time. I know my audience is going to love this. It just remains for me to mention or to ask you for confirmation of what countries in the world is this REMS technology available in? Obviously, the UK, where you are, and Melbourne and southeast Queensland at this point in Australia, where I am. Where else can you get REMS?
Well, Italy, because that's where it started. There are more REMS machines in Italy than anywhere else. There are a few REMS machines scattered around through Europe. Some in Eastern Europe, actually. Bulgaria's got a few. They've got some good sensors there. Increasing numbers in the US. And Echolite is expanding. I mean, it's only been going commercially selling machines for 6.5 years. So it is expanding. But we have Canada, USA, Australia, UK, the 4 English-speaking countries that are part of our worldwide group of REMS users. And then outside that, then, as I say, you've got the Italians and then some of the European countries. There are machines in South America, sporadically. So dotted around. And reality, I'm just trying to think that if you've got, for your clients who are in Australia, if they're on the eastern side of Australia, then Sydney and Melbourne, and I think there is one in Brisbane, as you said. So you've got some access to that. That's fine. If they're outside of Australia or outside the UK, the best place to go is actually to look at the Echolite. There's the manufacturer, the Echolite website. And they will be able to then, if they contact Echolite, they will be able to then point them in the direction of who's going to be the closest provider of REMS.
So I'll put all these links in the show notes. So we've got Echolite being the manufacturer, and then we've got so you're at osteoscanuk.com, and then let me see, and then we had so in Australia it's bonecompass.com.au, but I'll put all these links in the show notes. Great. I have thoroughly enjoyed this conversation, and I hope we can catch up again, because there's lots of other bone health related topics that I'd love to pick your brains on. So thank you so much for your time.
It's been great fun, and thank you for inviting me on. It's been I've enjoyed it tremendously. It's lovely to talk to people with like minds who've got a shared vision to try to improve bone health in women. And if we can do that, then that's a great thing to do.
Improve bone health and also reduce the fear and help women feel re-empowered to find out about what really matters about their bone health. It's not just bone density, it's the integrity or fragility being the opposite of that, of their bone that matters. And there is plenty that you can do to improve the health of your bones so that you don't have to suffer a fracture. Once again, Nick, thank you so much. It's been fantastic, and I look forward to speaking to you again sometime.
You're very welcome. Great to see you.